rolling in. So shall we get started? Yeah. Okay, thank you for tuning in to our second workshop seminar. Last week we had great papers focusing on former clinician perspectives of the Edinburgh outbreak, which Ray gave a really great kind of retrospective overview of, and visual analyses of anti-drug public health communication in England versus Scotland by Alex. So today we're excited to welcome Professor Jim Mills from the University of Strathclyde and Dr. Hannah Elizabeth, who will soon be on a welcome fellowship here at Edinburgh. So let me introduce our speakers. Professor Mills is a social historian of medicine, narcotics, and drugs. I first met him in Shanghai University. I was recruited as a postdoc on his Wellcome-funded Asian Cocaine Crisis Project. So it's a really fascinating project that crosses Britain and China, and he was a really great academic mentor. And he'll be speaking today on drug usage in early modern Scotland that was going through a lot of historic changes, and I think he's using a lot of local archives very carefully to bring that story out. Our second speaker, Hannah, is an early career contemporary historian of public health, and she has a particular focus on youth, families, and visual culture. I just asked her whether she'd class herself as a cultural historian. She said, between cultural and social historian. She works with Alex, Dr. Mould, our second presenter from last week, and she'll be talking today about meeting the care needs of HIV-affected women and children in Edinburgh. Just a few things before we start. Today's session will run until maybe 11:15 or so, because apparently it's Jim's wedding anniversary. So congratulations for that. And we hope to have our two papers, a little Q&A followed by some discussion, either as a whole or in smaller groups. I apologize, last time we didn't get around to breakout groups, so let's try it this time. So please, if you could turn off your videos and sound during the presentations for bandwidth reasons. Jim, please go ahead and share your work on early modern Scotland.
There we go. Thank you very much, Reiko. And thanks for mention of my wedding anniversary. Just as my wife walked into the caravan, so I'm afraid I'll need to pop off at about 11 o'clock. As I've just been reminded it is our 20th wedding anniversary after all. Right, what are we going to be doing this morning? I'm going to pop the PowerPoint up for you, and then hopefully I'll be able to talk you through it. So we'll go there. No, we won't. We'll go here, and then we'll share the screen. So can somebody give me a wave just to let me know that you can see the screen? And
we can see it, Jim, thanks.
Magic. Right guys, as I was just saying to Reiko before everybody tuned in, I've got no idea what I'm doing here this morning, because of course everybody's looking over the course of this series at HIV and its history and trajectories in Edinburgh, and here I am talking about opium in Scotland, but in the early modern period. I'll give you a sense of what I want to touch upon and why I'm touching upon it. The title of the talk is a general one called Poppies, Opiates and Pain in Early Modern Scotland. It's the title I think I've used for a forthcoming article in the Social History of Alcohol and Drugs, which has been accepted for publication and should be out for you to have a look at in autumn 2021. This in itself draws on research that I'm currently completing for a book with the title Before Heroin, Dangerous Drugs in Scotland 1664 to around 1980, which McGill Queen's University Press will publish in 2022. COVID-19 and archives permitting. Although I'll put a little teaser out there for you. We've got two possible titles. One's Before Heroin and one's Before Train Spotting, which the publishers seem rather more keen on. So if anybody has any great thoughts on which title we should be using next year, then do share them with me if you get the chance. I think my interests in this direction come from two sources. The first, of course, is that I'm not supposed to be researching this. As Reiko pointed out, I'm currently in the latter stages of a research project in which we're supposed to be looking at cocaine in 21st century Asia, which explains the second reason why I'm researching this, which is that I'm not supposed to be doing it. So obviously I've become distracted by other stories. This is a story that I find particularly interesting because once I began to have a think about what we know about these substances such as opiates and opioids before 1800, I began to discover that there was relatively little written on it, and particularly relatively little written from Scottish perspectives. And of course, the more I began to pursue this curiosity, I suppose, the more I began to discover that there's a much larger story out there about how Scotland, Scottish intellectuals, but also Scottish patients and Scottish doctors and medical practitioners began to engage with opium in the early modern period. So I guess what I want to do is give you a little glimpse of a fraction of this research, but it tells a story, I think, which particularly interested Reiko when she was thinking about this series, because it does have something, I think, intriguing to say about the relationship between global and local, certainly in terms of the arrival of opiates in Scotland in this period. What I'll do then is touch briefly on three issues. The first of these is if you like, the historiography, or which I shan't engage with for want of time, which presents or has explored this early modern globalization of substances like opium and opiates, which Jordan Goodman has called exitania. People like Wolfgang Schivelbusch and then Jordan Goodman and others who put together the Consuming Habits collection, David Courtwright and so on, have traced this early modern circulation of these intoxicating substances from regions in Asia and Africa and the Middle East, where they had grown traditionally and in environments which were suited to producing psychoactive preparations of these substances, and how these began to find new markets, particularly in Enlightenment Europe. And the story's really been about exitania, about an excitement, if you like, about these exotic stimulants and these exotic narcotics and their possibilities, which means that I'll come on to discuss something more local, and the relationship between this early modern globalization of these substances and the markets that grew for them in Enlightenment Europe, but also local uses of substances and local practices, which I argue actually paved the way for these more exotic arrivals in the early modern period. And again, just for those who are interested in thinking about more contemporary uses of opiates in Scotland, I'll touch very briefly at the end on whether anybody was consuming opium and opiates before 1800 in Scotland for purposes other than therapy and medicine. Right, let's rip through some examples. The second earliest example of opium actually being used in medicine in Scotland rather than simply being discussed in medical tracts comes in 1700 from the papers of Colin Campbell, which can be found in the National Records of Scotland. There is an earlier mention of opium, which I'll come back to at the end of this brief discussion. What we find is that the National Records of Scotland contains all sorts of interesting papers left over from the aristocratic estates of medieval and early modern Scotland, one of which, of course, is the Campbells. And this enormous set of records from the Campbell estates includes all sorts of interesting bills and accounts that have been settled by the estate managers over the years, one of which came from a guy called John Bailey of Edinburgh, who was described as a chirurgeon, a surgeon. And he essentially billed the Campbell estates, particularly Colin Campbell, who was a local laird in a place called Glendorel, at the end of 1700 for a set of medicines that he'd been supplying to the estate. And what we find is that across November and December of 1700, the estate ordered £50 worth of medicines, which included repeated orders for, and I quote, the syrup of white poppies. In fact, the household ordered 7 separate batches of syrup of white poppies in the space of 2 months, and purified water to use with it twice. And the syrup alone cost almost a fifth of that expenditure in that period, something like 10 Scottish pounds. What's interesting is what else was ordered alongside the syrup of white poppies, because essentially this is an apothecary's bill. So it doesn't include directions about how these substances were used, or indeed what they were even used for. It's just simply a list of substances, a list of prices, but interesting, they're listed by date. So you can see what else was being ordered at the same time as the syrup of white poppies. Syrup of white poppies was ordered 7 times, and it came alongside regular orders for spirit of hartshorn, rasped hartshorn, and cinnamon water. Now, I did a little bit of nosing around and discovered that all of these substances were also considered to be useful remedies for stomach disorders, loose bowels, if you like. And the syrup of white poppies, opium medicines, are one of their many medicinal or therapeutic uses, is to calm down loose bowels and to induce constipation, if you like, in stomachs which have been upset. So you can see that the hartshorn, the rasped hartshorn, the cinnamon water, and the poppies all being used together on a regular basis suggests that the whole household has been afflicted by some sort of stomach disorder. This all comes to a juddering halt about December the 10th, when, if you like, a new set of medicines are being ordered, something which were called purging powders, the recipes for which could vary from apothecary to household to household. But the idea here now was to enhance or encourage excretion. And again, from reading around what others have published on medieval and early modern medicine, this seemed to be a standard treatment for the loose stomachs of the period, the stomach infections of the period. In other words, what you've got is an attempt to stop the stomach from constantly evacuating itself, and in order to calm down the stomach. And then once whoever was treating the patients with the substances had decided that the stomach emergency was over, then purging powders were used in order to try and clear out any remaining toxins. So, without boring you anymore with what was happening to the Campbell's stomachs in 1700, what we've got here is a sense that the syrup of white poppies was being used in ways that are familiar, from the 19th and the 20th centuries. The white poppy medicines were being used partly to relieve pain, partly to induce rest, but seem to have been included in a regime of medical treatment here designed to stop stomach disorders in order to calm down loose bowels and agitated stomachs. Right, let me flick on to another example. What I found from starting to plough through some of these estate records and using the excellent online catalogues of the National Records of Scotland office in Edinburgh was that there was evidence from the same sort of period that Scottish households weren't simply using opium medicines, they were actually making them on site. One particularly good example comes from the Clark family of Pennycook, a family that worked themselves up for being wealthy merchants in the middle of the 17th century to become major movers and shakers on the Scottish political scene throughout the 18th century. In their collection, there's something like 83. There's something like 83 little medical recipes, all scribbled down on scraps of paper. The first of which was dated to 1666, the last one of which is dated 1783, but not all of them are dated. So we can get a sense that these medicines are drawn from across the late 17th and 18th centuries. Unfortunately, the recipe for the syrup of poppies wasn't dated, but it very clearly showed that the household had a recipe which involved getting hold of 7 ounces of white poppy heads, 6 pints of water, presumably purified water, but there's no evidence of that, 12 ounces of sugar, and basically boiling the whole lot up together and straining it over the course of a few days in order to get the solution from which included extracts from the white poppy heads. Interestingly, included in the bundle, kind of stuck about 4 or 5 recipes after this recipe appears in the order, is a pamphlet. And the printed pamphlet, which I'll show you in a moment, is titled "The Method of Curing Smallpox," first written in the year 1704 for the use of the noble and honourable family of March by Dr. Archibald Pitcairn. There we go, good. Now, so there's the printed document that sat 4 or 5 recipes on from the syrup of white poppies recipe in the Clark's collection. Now, his recommendation is for a set of treatments which he published in 1704 for smallpox. And of course, smallpox was to go on to be one of the great killers of the 18th century, and quite particularly smallpox in children. Which again is no great surprise because smallpox turned out to be particularly fatal in children in the 18th century. And just to whip through his regime started with the liberal use of lock leeches. And those of you who live in Scotland will immediately think of locks and leeches and recoil with some horror. Meantime, give the child a spoonful of syrup of white poppies at night, and in the night time, till sleep or ease comes. Once the fever passes, a handful of sheep's pearls, which I've not been able to quite work out what they are yet, was to be administered once every 5 hours, but this was to be sweetened with syrup of red poppies, and at night the administration of white poppy syrup was to be continued. Around the 8th day of the illness came a crucial moment. Give the child a drink of barley water sweetened with syrup of white poppies. This will make the child spit, which saves the child. And in the event that the disease loosened the bowels, Pitcairn's advice was once again to turn to opiates. Stop it with syrup of poppies and 5 or 7 drops of liquid laudanum, given now and then till it be stopped. So what have we got here? So far, I've shown you examples that white poppy medicines were being bought from the apothecaries, but actually the households were also ordering white poppies and cooking up their own concoctions from these exotic imports. Archibald Pitcairn, at the time, I think was the University of Edinburgh's professor of chemistry, and he was also to go on to serve as the Royal College of Physicians, as the head of the Royal College of Physicians, but actually had to resign from the Royal College over this controversial new recipe. So if you like, and no time to dwell on Pitcairn, smallpox pamphlet, which is tucked away near the recipe for syrup of white poppies in the Clark's set of recipes. This is bang up to date. You know, this is the leading treatment of the turn of the century for smallpox. And as you can see from Pitcairn's statement, it uses not just white poppies, but other poppy preparations. Hang on, what does that mean? Because here we've got we've looked at multiple uses of the white poppy, but here we've got Pitcairn advocating use of white poppy preparations, of laudanum, which of course was tincture of white poppy, but also he's recommending use or including use of syrup of red poppies within his treatment regime. Now that got me thinking, because I've noticed that in the earliest example I can find of one of these aristocratic households ordering white poppies comes in the papers of the Earl of Glenorchy, when in 1665, John Murray, who was an apothecary in Edinburgh, sent a bill to the Earl's estates for medicines that had been administered over the previous year. And this included multiple orders for laudanum in February, March and April, but also an order which was significantly more expensive, interestingly, for syrup. Well, and this is the exact entry, SYR : Papara erat. Now, Papara erat is another word for the red poppy, and the red poppy occurs locally in Scotland, in hedgerows and in unploughed fields and so on. So here we've got a story starting to emerge from these documents that the red poppy, in other words, the local poppy, is being used in order to prepare medicines alongside the use of the white poppy. Now, not just that, in the Murray family collection from the 1730s and the 1740s, again, they're not just, there's evidence here that they're making on site for themselves preparations of the red poppy, just as the Clark family in Pennycook had written down a recipe for a syrup of the exotic white poppy. And there's your recipe for those of you thinking of doing this at home. You take 2 gallons of brandy, you take a peck of corn poppies, in other words, of the red poppies, and then you bash them in with some mace and nutmegs and brandy and mint and all sorts of other things in order to produce your syrup of red poppies. Now, the chemists among you, or the botanists among you, will know that red poppies contain a range of alkaloids called, the chief amongst which is ruidine. And ruidine is a mild analgesic, which acts on opium receptors in the body, we now know. So to me, it looked like here we've got an interesting story where you've got a long-established use of local poppies and a knowledge of local poppies amongst medical practitioners who have decided that the new white poppy can be integrated into their existing knowledge of red poppies, but albeit with an awareness that the white poppy is far more powerful. And for those of you interested in non-medical use, I'll just draw quick attention to this because my conclusion so far is that there's no evidence that opium preparations were being used to service habitual use or for recreational purposes much before the 1830s. The only evidence comes from this extract where a doctor is writing to his brother-in-law about the health of his sister, who appears to be pregnant. And he's saying, well, look, if you really must use opium, use it hesitantly, because once you start using it, you will find it very difficult to get the patient to stop using it. So I've run out of time. So my core conclusions are that opium medicines were consumed in Scotland, or have been consumed in Scotland since at least the 1660s. But opium medicines have been based on both imported white and local red poppies. White poppies and red poppies were used alongside one another, and it does not seem that the former supplants the latter in this period, and exotic white poppy medicines were adopted and adapted by those used to working with preparations made from the red ones. And finally, I can't find any evidence that poppy substances were used for anything but pain and therapy in Scotland, much before the 19th century. Right, thank you, Reiko.
Thank you for a fascinating paper. I found 3 things really interesting. Maybe I'll get to that in the Q&A, but it was certainly the line between therapeutic use and overuse is something that's a universal question. So thank you very much for that. Let's move on to Hannah's paper.
Okay, am I all right to share screen?
Yes, hold on. Let me just... All right. we can see it, so thanks.
Okay. All right, so this is based on some, well, I guess it feels a bit preliminary to me still because I've only just really started, but I suppose it's not that preliminary anymore. I'm just going to kick straight off because we've had the background from last week's papers, so hopefully everyone will know what I'm talking about more or less. Okay, so while government interventions such as the Don't Die of Ignorance campaign are often lauded as a brave and effective intervention which shifted the discourses around AIDS from a gay disease to one affecting all sexually active publics, the needs of HIV-affected children and their family were woefully underserved by the government's large-scale public health education responses. As the extent of AIDS effects on children became ever more stark, social workers scrambled for funds, expertise and materials they needed to help and empower this underserved and varied group. Recognising the AIDS crisis in Edinburgh particularly affected women, social workers began to seek the voices of HIV-affected mothers and children in an attempt to produce texts and protocols which bridged these gaps. The aims of these texts were to foster agency and lessen the burden, lessen the emotional burden of HIV diagnosis and treatment. In addition to educational materials, new spaces were also created to care for HIV-affected families such as hospices, community cafes and multi-use centres. This was interdisciplinary and collaborative AIDS activism born out of the daily fight for resources, information, space and empathetic treatment. This activism can be traced in texts both academic and creative and was at the very least a backdrop for many women's experiences of HIV and AIDS in Edinburgh in the late 20th century. So this paper begins by briefly discussing how HIV was recognised as an intergenerational health crisis, sketching a picture of the late 80s and early 90s HIV outlook for women in Edinburgh. I'll then move on to discuss the place of women's activism briefly around HIV and care and child rearing. This will be a necessarily elliptic history as I don't have time to draw out the many strands of women's HIV activism which concentrated on meeting the needs of people within the prison system, queer communities or sex workers. Here, I'm going to be concentrating just on a few sources and resources which women were demanding and producing, often in collaboration with the health and social services to meet the care needs of HIV-affected women. I'm also going to try and concentrate on the kind of multiple difficulties encountered by women who were also affected by drug use within either themselves or within their families. Then I'm going to draw some conclusions. Okay, sorry, I should have had that slide up. Apologies. So the title of this slide is from This is a Family Disease. It's actually drawn from an oral history interview that I conducted during my PhD with Naomi Honigsbaum, who was a social worker who was instrumental in the creation of much of the policy and practice which governs social work with HIV-affected children in Britain in the 1980s and 1990s. During the interview, Honigsbaum explained with some frustration that in 1987, when she began to work in earnest on the familial dimensions of HIV, the impact of the disease upon women and children in Britain was largely unrecognised. I begin by quoting a social worker rather than an activist, in part because the line between social worker and activist and vice versa is often rather blurry. This is a history where the line between producer and produced for is blurry. The HIV-affected social worker or healthcare worker sometimes sharing some of the experiences of the HIV-affected mother. The HIV-positive woman becoming a producer and consumer of materials and spaces intended for her care and the care of other HIV-positive and HIV-affected individuals. Moreover, while Honigsbaum was based in London, like many other social workers attempting to figure out the care needs of HIV-affected families, she travelled to Scotland on fact-finding missions to learn from the emerging policy and practice to be found there. Global movement has always been part of the stories we tell about HIV, with patient zero blamed for bringing HIV to new places and the circulation of biomedical experts around the globe celebrated as an optimistic effort. Smaller scale transnational exchanges of expertise are yet to be adequately attended to. Leaflets, books and people travelled into and out of Edinburgh, disseminating ideas about how to meet the care needs of the HIV affected. As this paper will demonstrate, in the field of HIV-related social work and social care, Edinburgh looms particularly large in the global story. In Edinburgh, the number of women affected and infected by the virus created a sense of urgency, a scramble for expertise, information and resources, which could be targeted at meeting the specific needs of women. By 1985, an estimated 50% of known injecting drug users in Edinburgh were thought to be infected with HIV, a third of them women. By 1987, Edinburgh accounted for around 30% of all cases of recorded HIV positive women in the UK, and the highest rate of recorded cases in HIV overall. As we heard last week, the high rate of infection was in part caused by an earlier increase in IV drug use among younger populations and the limited availability of clean needles for injection. It's hard to estimate how many children were affected by HIV in Edinburgh in the late 1980s and early 1990s. While infection rates among infants were recorded and those who had an infected mother monitored, children with siblings or other non-parent relatives with HIV were not. By 1993 in Edinburgh, of those 1,034 HIV positive individuals identified, there were around 500 children thought to be affected by parental infection. But these estimates were all based on having an infected mother. So sometimes children who had an infected father weren't necessarily recorded amongst these statistics. So it's quite a sketchy field. The already challenging care needs of families affected by past or present drug use were complicated by the additional burdens of HIV. Parents who may have encountered difficulties with social or healthcare services were often reluctant to ask for help for fear of being declared unfit parents. And intergenerational drug use within some families made the use of kinship networks for childcare more difficult. Families affected by HIV and drug use across generations also often faced multiple losses as siblings and parents were affected by separations through state interventions, family breakdowns and deaths. Children could have experienced neglect, embarrassment, or become carers of parents or siblings, or in worst case scenario, suffered the loss of a primary carer. While the emphasis remained upon keeping children with their biological family or extended family within social work, HIV affected and HIV positive children sometimes did enter the care system. Okay, so the title of this slide is drawn from the testimony of a Scottish mother who was living with the realities of bringing up her adoptive HIV positive son, her tiny time bomb, in 1988. The quote you see here is a shortened version which explains some of what it was to be an HIV-affected parent, the moment of diagnosis, the empowering effects of AIDS education, the need for familial and emotional support, the discomfort of telling HIV-affected children about their diagnosis or the diagnosis of a loved one, and the assertion of agency found through disclosure, but also the day-to-day of living with a child with AIDS. So I quote it here not merely to illustrate the challenges faced by HIV-affected parents, the not knowing, the uncertain future, the difficulty of a sick child, but also to illustrate the kind of testimony that social workers were gathering and were informed by during this period. They found out what the needs of people were, what the care needs were, by asking parents and asking children. This quote, which is longer in the original, was one among many in the training manual, Living and Working with HIV, which was published in 1989. The book had a wide circulation among professionals and it was not limited to Scotland. As a text, it emphasised the need to listen to parents and children living with HIV in order to meet their needs. While the manual and manuals like it reassured social workers that they already had many of the skills that they needed to help and empower those affected by HIV, the social services also recognised a dearth of appropriate materials for social workers and for the HIV affected, and a need for specific training. A lot of this training was kind of brought about by linking up people who were experts in, working with IV drug using communities and people who were experts in working with children, and then bringing in kind of social workers who were used to working with chronic illness. So there was a lot of sharing of expertise. The high rate of infection among female IV drug users created specific complex care needs. Social workers, aware of the care burden many drug-using women carried, caring for children and partners, some of whom were HIV positive, were aware that this would only become more onerous as HIV progressed. Social workers were concerned that HIV positive women would continue in their care roles to the detriment of their own health if useful support was not forthcoming. emphasis was placed, therefore, on empowerment to allow women to maintain these care roles, to look after their children, to look after their partners, to look after themselves for as long as possible, with respite care and flexible intervention made available, which drew on wider kinship networks and supported wider family networks. In some cases, this was impossible, as was the case with Thomas, and children entered the care system. While the social services identified many challenges associated with parenting HIV-affected families, testing and serostatus disclosure were identified as presenting particular problems for parents, while the earlier manual, Living and Working with HIV, expressed frustration with parents' unwillingness to tell their children about HIV. Later publications like HIV/AIDS and Children, A Cause for Concern, contextualize adults' unwillingness to speak to children about their viral status. It was understood in this later publication that adult reticence was not wholly the result of stigma and a desire to manage the flow of information, but was also the product of an anxiety about saying the wrong thing. In an echo of many parents' and teachers' anxieties regarding teaching safer sex and HIV education more generally, the study identified that staff and parents often felt that they lacked the skills and confidence and courage to confront HIV illness in children, and frequently expressed the need for more expert help and guidance in this task. Reticence presented substantial obstacles to the care of HIV-positive children, however, especially teenagers, who sometimes rebelled against condom use and clinic visits without knowing the risks involved. So there's quite a lot of oral histories from medical practitioners talking about teenagers discovering their HIV positivity when they were sort of older teenagers, and then starting to refuse treatment or starting to refuse to go to the clinic because they had no idea why they were being made to go to clinics for kind of frequent checkups. And you get this kind of, it created problems with the care regimes in terms of the medical care, but also in terms of the more kind of social care side of things. HIV-affected mothers were involved in the production of resources for the consumption .
We might have. Hold on, I will try to get Hannah back.
Hi, I'm not sure how far back I need to go in my presentation.
Maybe just a minute or so back. I think we lost you. Okay.
While the social services identified many challenges associated with parenting HIV-affected families, testing and serostatus disclosure were identified as presenting particular problems for parents. While the early manual, Living and Working with HIV, expressed frustration with parents' unwillingness to tell their children about HIV, the 1991 publication, HIV, AIDS and Children, A Cause for Concern, contextualized adults' unwillingness to speak to children about their viral status. It was understood in this later publication that adult reticence was not wholly the result of stigma and a desire to manage the flow of information, but also the product of anxiety about saying the wrong thing. Reticence presented substantial obstacles to the care of HIV-positive children, however, especially teenagers, who sometimes rebelled against condom use and clinic visits without knowing the risks involved in such behaviour. So there's examples in oral histories of teenagers starting to refuse to go for their kind of regular checks because they didn't understand why they were being made to go for regular checks. And then teenagers finding out that they're HIV positive, becoming very upset by that and then refusing treatment subsequently. So this was a significant issue when it came to care, but there was always a tension between the rights of the parents to confidentiality and the rights of the child to know about themselves. So this was something that social workers constantly had to attempt to kind of manage in their role as kind of mediator, and their responsibility to parents and children. There we go. HIV-affected mothers were involved in the production of resources for the consumption of parents and children affected by HIV, aimed at reducing the emotional burdens around this HIV disclosure. For instance, It's Clinic Day is a book written by HIV-positive mothers about a visit to an HIV clinic, offering an accessible discussion of HIV as a means to disclose serostatus. Indeed, It's Clinic Day depicts an idealized visit of an HIV-affected mother and daughter to an HIV clinic, scripting empowering interactions between healthcare workers, parents and children, while it delivered simple HIV/AIDS education messages. Through the book, Stevens provided more than a rubric of helpful behaviour. When read aloud, the words of the adult characters function as scripts for adults struggling to talk to their children about HIV. The picture book is a fanciful realisation of the destigmatising and empowering practices which were advocated by social workers and activists, acting as a script and a demonstration of a much needed resource, but also a request for more and better care for HIV-affected children. So it includes doctors talking very gently to the child, but also being open with them about HIV. It shows HIV-affected children playing together in a space that's specifically designed for them. The book had a wide circulation, which went well beyond Scotland, and enjoyed a second updated edition. Similar picture books produced in Canada and America were also disseminated by those involved in HIV care across the UK. So these are the kind of texts that we can use to kind of follow the kind of global patterns of knowledge, but also kind of care practices, these slightly more kind of interpersonal practices. And it really shows just a little bit of Edinburgh's kind of global impact in terms of the field of HIV care around HIV-affected families. Working with HIV-affected parents and children was not just educational, medical. Another method used by social services to meet the care needs of women and children affected by HIV was to create spaces to facilitate their care and well-being. These were not limited to hospices and medical spaces, but included finding and rethinking existing spaces which could be used to help and organise and support families. Spaces for children to play and adults to engage in art were emphasised, with community cafes and hospices ensuring dedicated space and staff were made available to facilitate these activities. Another key factor in finding space for children and parents affected by HIV was the provision of respite care, as I mentioned before, for adults and child carers. Holidays were organised where HIV-affected children could be brought together among peers with some idea of what they were going through. Day trips were organised, and several of the institutions involved in this kind of work brought caravans and placed them in beauty spots, which could be used by HIV-affected families for holidays in nature. So you get a sense that people were trying to get people out of the city, which I think is quite interesting when we think about the kind of regional nature of HIV. Okay, some conclusions. Social workers identified, I seem to have skipped forward, I do apologise. In the early 1980s, the specific needs of families affected by HIV in Britain, while recognised, were not prioritised. HIV's emotional and social impact was quickly identified as a formative aspect of the effects on individuals and communities, but any public health and social care response to these experiential facets of HIV was superseded by a public health response aimed at transmission prevention, often to the detriment of the agency of those who already had HIV. It quickly became clear, however, that the social aspects of HIV infections, such as the stigma and myths which became associated with the disease, were affecting the success of the public health response. Assumptions about who got the disease, how it was transmitted, and the trajectory of HIV affected the allocation of resources and the impact of education, leaving the needs of key groups such as women and children at worst neglected and at best misunderstood. Recognising an as yet unfulfilled need, the HIV positive, those who knew and loved them, and the social service sector began to address the problems associated with the social costs of HIV, producing materials and spaces for the HIV positive, their families and communities. These resources attempted to meet the medical, educational and emotional needs of its audience, giving voice, returning agency and respecting the dignity of those affected by HIV. In Edinburgh, the high rates of HIV among IV drug users resulted in a proliferation of pioneering resources, medical, emotional and educational, targeted at meeting the intergenerational needs of the HIV affected. Such expertise, while affected by the geography and specifics of the city, was not created in a vacuum and reflects the city's place as part of a global network of urban centres meeting unique challenges related to the demographics of each HIV-affected population. All histories of HIV are regional, transnational, and to some extent global. And as I have shown, this was certainly the case where HIV-related care and social work in Edinburgh are considered. Thanks.
Thank you very much. So we've had
Sorry, my internet cut out exactly the wrong point.
That happens. That happens. Well, shall we move into 10 minutes of Q&A for our presenters? If you don't mind, can I start by asking you both a little bit on your methods, because you're both historians. What can you read from the sources you use, and what new stories are coming out?
Well, I guess the answer to that from my perspective, Reiko, is I'm not sure yet. I mean, part of the joy of researching this period is that I'm not in the least bit qualified to do it, as most of my work has been on the 19th, the 20th, and even snuck into the 21st century. So the joy of working with early modern scraps of paper with handwritten recipes on them is unbounded. I think what's interesting, and it kind of comes back to the some of the conclusions I hastily spat out, is that my expectations aren't being met, in as much as I'd gone in, I think, to the archives expecting a story about non-medical use to emerge much earlier than I'm finding. Essentially, the range of sources I'm using include the ones I've shown you. So there's bills that show what households are buying from apothecaries and medical professionals. There's the household recipes, which give a glimpse of what's actually being used or prepared rather, what's being made on estates and within these grand households. And then there's the medical discussions of the period. So, alongside pamphlets like Pitcairn's, there's a range of discussions that begin to emerge in Edinburgh's scientific and medical community, which really intellectually is one where the Edinburgh medical establishment is engaging intensively and very early in scientific discussions about opium, about trying to work out exactly what it does. And particularly, as you would probably expect in Enlightenment Edinburgh, there's a conscious dismissal of, well, we're not going to buy any of the myths that tend to come with opium. We want to find out for ourselves, using empirical methods, exactly what opium is and how it works and how it may be used therapeutically. So I guess the answer is that what I've found from the sources that I'm using is that the story is almost entirely medical and therapeutic. But there are no discussions in medical and scientific circles until very late on about some of the hazards of overusing opiates in therapy, habitual use and addiction and so on. And there's absolutely no discussion of recreational use, which I think I've been slightly surprised by. Not to get too far ahead of my own story, but the first discussions I really get by in Scottish medical circles of recreational use don't come till the 1830s. These come after the alarms of the 1820s about the use of opiates as poison in criminal cases. So a long answer to your short question is that in many ways the sources that I'm using from this period are as much a part of the puzzle as what they reveal. So, you know, for me, part of the fun is trying to work out if there is recreational use, which is certainly the suggestion for historians in other places, London and in the Netherlands and so on. You know, there's a suggestion that opiates are being used recreationally in this period. There's no discussion of that. So I'm still trying to work out whether that's because doctors and scientists and other observers simply weren't interested in looking at it, or whether that's because there wasn't any.
I think for me, the thing that I'm always surprised by is when I come across children's voices in the sources and how they get managed by the adults that are attempting to mediate them. And social workers were obsessed with trying to capture children's voices and insert them into their text. But despite the fact that they're constantly talking about the agency of children, and, you know, so 1989, you have the Children's Act in England, and then it comes through in Scotland a little bit later, which says that children should have some kind of agency over where they end up, not in terms of if they say they don't want to live with their parents and they don't have much power there, but within the social work system, if they enter the care system, they're supposed to have some kind of power. The way that their voices get used and deployed within adult texts is always really problematic, quite frankly. Like they're added to create a sense often, I mean, this is something that Jenny Crane has written about, as like a level of cuteness to texts. So I think for me, that's one of the things that I find surprising. Like, I want to bring children's voices into this work, but they're very difficult to manage because it's often really unclear what circumstances those children's voices were collected, what level of consent those kids were giving in order for their sources to be used and deployed by social workers as object lessons. So then for me as a historian to come and find these sources, I don't want to then turn them into object lessons. So there's actually a quote that I really wanted to include in this paper, but I couldn't find a way of including it with enough space that didn't turn it into just a child being sad. So I think that for me is like one of the biggest methodological challenges with working with social work texts that, I mean, I've been grappling with this for a while, but it's kind of an unanticipated challenge because I maybe perhaps naively thought that social workers would know how to work with vulnerable people without like regurgitating their words unthinkingly or without enough context. So that's one of the big challenges, I think, methodologically, to include voices without turning voices into object lessons or illustrations rather than like a kind of, I don't know, a proper history.
I think Virginia had her hand up, and then maybe Steve.
Yeah, I guess it was a question for Hannah about structures. I was thinking of the rather different nature of the Scottish health and social care system, and isn't there a greater integration of social care and health in Scotland? And I just wondered whether that impacted on the way in which these families were responded to.
Yeah, definitely. I mean, there's in Jackie Mock's oral history, she talks about entering homes herself as a physician, but there's also a health visitor with her, and there's this level of kind of integration between you get a real sense of social workers and health visitors and practitioners working more closely together, and there's a sense of kind of immediacy of shared expertise that kind of comes across in the sources, and in terms of the way that social work texts that come out of Scotland at this time are written. There's quite a presence of multiple expertise within those books that is not as obvious in the social work manuals that I see coming out of like England. based in kind of the areas of expertise that are located in London. So yeah, I think that is true. I have to admit, I've been very blinkered by my trying to deep dive into the way that social workers are imagining and trying to meet the needs of HIV affected families in Edinburgh. And I think I maybe need to think more widely about this field. But yeah, like there's a lot of, it's interesting the way that kind of the Children's Act affects, it supposedly, in terms of legislation, it affects Scotland later than it affects England and Wales. But in terms of thinking and in terms of approach, I don't think it necessarily does, because the minute that happened, you know, that's legislation that was catching up with the way that social workers were thinking about children and thinking about whether they were better off being with their families, and about what kind of care looks like and how to kind of support wider kinship networks. That was already happening in social work, and then the law sort of caught up a little bit. So yeah, it's difficult for me to kind of pick out stark differences, but I do think that yeah, there was a closer kind of exchange of expertise taking place between social care and healthcare in Edinburgh. But also, I mean, Edinburgh is also the place that got the funding, that had these new centres that got set up. So it's also like I don't know if it was maybe a little bit more separate in other cities, because, you know, Edinburgh got the Paediatric AIDS Resource Centre set up by Jackie Mock, and that got some funding, and it also got its specialist AIDS centres at the City Hospital, and then, you know, Milestone House got built, and all of that happened quite, I mean, relatively speaking, quite quickly. So that's also quite difficult for me not to be distracted by those things, if you will.
Thanks.
Should we have Jim, Steve, and then Philip?
I was going to say to Jim, if he'd take it on board, that maybe the current issue in pain management, with a lot of strong opiates prescribed, and now the very significant problems, not least in a drug-dependent population, whether in the UK or in the States, is an interesting parallel. At least it's the closest I've been to what you've been describing, but a different population.
Absolutely, Philip. I think what's really interesting is, you know, this story about the red poppy predating the white poppy, and then the white poppy predates morphine, and morphine predates heroin. So it's kind of observing, you know, sometimes I think these historians of drugs can focus on these different substances and separate them out. I think what's proving to be interesting is that the history of these substances seem to blur increasingly into one another. So, you know, we may find that there's an enthusiasm for morphine and heroin as medicine in Scottish medicine and medical circles, because, you know, using opiates and different forms of opium preparation seems familiar and just seems part of the culture. And the further backwards I go, the further I find this story stretches, you know, back into the centuries. So again, I think there's an interesting question there about how far, you know, there are direct links between the period I've been talking about today and stories that, you know, the stories that we're dealing with at the moment about opioids. Thanks for that. I think ask you. Oh, sorry, Philip.
Sorry, I was going to rope in Hannah on this, in that the population of women and children presumably predominantly living in relatively deprived circumstances, whereas activism probably came in at that time from relatively better educated women. I'm not sure whether foster carers or families who adopted. My older daughter was a social worker for 5 years in Muirhouse till as recently as 4 years ago. It's a hard road to hoe. And we remember the inverse care law that in fact the services were not brought to bear in areas of deprivation, whereas leaders like Jackie Mock and others managed to reverse that in a way in a place like Edinburgh.
Yeah, certainly. Like one of the biggest problems that social workers kind of encountered was this kind of this multiple deprivation. So sort of trying to manage the needs of people that were not, that it wasn't just that HIV was an issue, it wasn't just that drug use was an issue, but there was, you know, issues around people having a safe space to sleep, and, you know, having enough food, and, you know, very, very basic needs weren't being met. And yeah, activism, especially in the early days, I mean, the kind of activist groups in Edinburgh emerged, I mean, around HIV first, it emerged within men who had sex with men, so queer activism, but very, very quickly, families who were affected by HIV and drug use started to support one another. So you see the emergence of groups of people who weren't necessarily kind of middle class parents of adopted children, but were the parents of teenagers who had started taking heroin and then subsequently become HIV affected. So you saw sort of people in their sort of 40s whose all their children had been affected by drug use, who then started to support other kind of parents in their kind of 40s and 50s. So you see these very small grassroots activism taking place that was more based around those kind of deprived areas, if you will. But yeah, no, there was definitely a moment when it was quite a kind of top-down-ish or middle-class kind of intervention, if we think about the way that class interacts with these things. But I mean, it's also important to remember that churches became involved very quickly in activism around HIV as well, and the class dimensions there are a little bit more messy again. So yeah, the geographies of where the activism was coming from, or the kind of class dimensions of where the activism was coming from, is something that I still need to unpick. But because I've been looking at social work, and because I've been looking at families, it's the kind of experiential expertise of the parent who has lost a child, or the parent who has been affected by a child's drug use, then becoming an activist on a very small scale, that I've been most interested in following, because that is in some ways unique to Edinburgh. The shape of that activism is in some ways unique, and that makes it particularly interesting, I think.
All right, should we let Jim? He asked.
Yeah, thanks, Rachel. Hannah, I guess I've always been fascinated by this story about Edinburgh. So I wonder if you can tell us a little bit more about social work traditions and the social work departments in Edinburgh in the 1980s. So is the innovative response and the rapid response to what was emerging in terms of HIV in Edinburgh consistent with the department as a whole? You know, was it seen as being particularly active and innovative throughout this period? And I suppose the second question that relates to that is how did the HIV challenge, I suppose, sit alongside everything else that the social work department was trying to do? So, you know, aging populations and deindustrializing parts of the city and so on. You know, was the HIV response actually part of a much wider response to the sudden social problems of Edinburgh in the 1980s?
No, I don't think so. Probably the. Yeah.
I'm trying to think. To be honest, I can't answer that question yet. I mean, it's an absolutely, like, it's a really excellent question. There was a lot of expertise already in working with IV drug users. I mean, part of the reason why, you know, the medical profession figured out that HIV and IV drug use was going to be an issue is because they'd already paid attention to the fact that there was a hepatitis outbreak that needed paying attention to. So that was already happening. In terms of the social workers, I can't say if they were just a good group of like rapidly responding social workers. Certainly they had expertise in IV drug use and working with families where IV drug use was an issue. But also social work in the kind of late 70s, early 80s is an interesting field that is like picking up and doing new things and thinking in new ways. So that isn't just unique to Edinburgh. There is a sea change. There's something interesting happening at this point in terms of social work. But yeah, like I definitely need to dig deep into the character of what was going on. I mean, it's not just Edinburgh that social workers were doing fact-finding and observation missions on. You know, they were going and spending a week with social workers in Edinburgh, but they were also going to Detroit and New York and San Francisco. So, you know, and Glasgow as well. Like it was on the list of like where you go to observe social workers working in this field, because it was seen as a place where people were figuring things out. But it wasn't the only place to go, but it was definitely on the list.
Can I make an oral history comment? I would suggest my remembrance of what happened, which actually is not just to do with social work, it's actually to do with every branch, was that there were people that were really interested and would take it up, and there were people who wouldn't. So I don't think it was a departmental issue. I mean, Jackie's involvement in a sense was because I phoned her and said, hey, because she's a classmate of mine, and I said to her, you know, we've got kids and women, what, you know, any idea what to do? Would you like to be involved? And she said, and she took it up, you know, because she was interested. Now, there were lots of other people, in a sense, who, if you'd have asked, and the same with social work, there were a number of key social workers who, you know, would run with it, and but there were plenty who would go, no, we can't do that. That's not a possibility. That's not in the department setup. You know, so I think that it is the case. To me, it's a series of individuals who took up the challenge as it came along and said, oh, this is something interesting. If you like, it's different, I don't know, whatever, I'm going to go with it. And there were people who didn't for whatever reason. I mean, I have to say that the hepatitis B scare is one of those things that in other cities, I don't think was really appreciated. I mean, the fear that went with that hepatitis B outbreak, which actually, you know, you realize it lasted 10 years or more and had a big influence on, and I think, again, what you might have is that the younger social workers, the younger surgeons, the younger doctors who became, if you like, in charge of departments were influenced by that event. But I'm saying I don't think it's to me, it wasn't a policy event. It was people running with it. And similarly with, actually interesting thing about Edinburgh was that I always find fascinating was that the population was ahead of most of us about what was going on. I mean, the best bit was that we were trying to discourage everybody from having kids. You know, obviously we were going, oh, you don't have kids. You know, they're bound to be HIV infected. You must have kids. And they said, rubbish. That person, they were all positive. They've had kids. Their kids are fine. They don't have the virus. And so they were well ahead of us in terms of information sometimes, or about, you know, the odds are we should, and I mean, you know, the obstetrician that we worked in with, he said, look, you know, it's amazing how high the barrier has to be before women will agree to an abortion. You know, you have to almost give them, you know, you've had German measles, that your child is going to be blind, is going to be, you know, they still wouldn't necessarily agree to an abortion. And he said, you know, HIV, it's pretty small risk. so it's not going to change. So I'd say you're looking at history involving individuals who decided to go with it. Thanks, sorry.
No, I mean, it's an important point. I mean, one of the things that social workers were grappling with was bigotry amongst social workers. So social workers who weren't used to working with IV drug users or sex workers or didn't want to work with men who had sex with men suddenly had this, you know, this is your job now, you have to deal with XYZ. Here's a child whose parent has, you know, been a drug user or has, you know, contracted HIV by kind of sexual means, and suddenly, you know, they were confronted with this. So a lot of the training, whilst it was about integration and learning from other people's expertise, a lot of the training was also about addressing bigotry amongst social workers, and it's dressed up very carefully and politely in the social work manuals, but that is also a lot of what was going on. So yeah, definitely there were people who didn't want to be involved in this. But yeah, I think it was an individual. Pardon?
Well, just the more I think of it, you know, if there was a point of connection between our two papers, it was this about, you know, medical, Edinburgh's professional establishments. So, you know, if what Pitcairn was trying to do in 1700 was deal with a new problem, smallpox, and deal with it in a controversial way, because if I remember rightly, he was all for sweating, whereas the establishment orthodoxy was all for purging or blistering or some such. You know, but at the time, you know, this was the Edinburgh medical establishment, but it became bitterly divided on this issue. But it's very easy just to spot the story of the winners and to say, oh, well, look, you know, Pitcairn, Edinburgh was very well, you know, it turned out Edinburgh saw off smallpox because, you know, his use of these painkillers enabled people to survive the fever and so on and so on and so on. So he kind of, you know, jumped forward 200 years to the 1980s. And
can I jump in? Because the other thing that is a connection between your two papers is this aspect of, you know, what the theme of the workshop is the relationship between the local and the global, or the local and circulation. And I think there's really interesting aspects that, you know, both of you raise really interesting questions there about the relationship between the local and the exotic in Jim's case. I mean, I was really interested in the relationship between the red and the white poppy, the red poppy being indigenous, vernacular, the white poppy being exotic. And I just wondered if, you know, there is I don't know the 17th century at all well, but there is, you know, a strong movement, Puritan movement for local drugs for local people, this sort of providentialist approach of Culpeper. And I wondered if that was a part of what was going on here, that local drugs are safe. You don't really need to talk about the red poppy very much, but the white poppy is one that needs professional control. It's coming in from outside. So, I mean, is there a local versus exotic issue there? And how is there a translation of the exotic into the local? And likewise, I mean, Hannah, most of the discussion of your paper has been about the peculiarities of Edinburgh. But you know, say you have fantastic data on the way that stories from Edinburgh or voices from Edinburgh circulate. And again, is there a translation problem of the peculiarities of the Edinburgh situation to what's being said elsewhere?
Yeah, it's just a quick response, Steve. I think that's a really interesting question. There's a little book published about the same time as Pitcairn's active, called Moncrief's Remedies, and it quickly goes into a second edition, and it's specific. I can't remember the correct title offhand, but it's like Moncrief's Remedies for the Poor and the Disabled of Scotland. And in there, there's a really fascinating list of late medieval medicine and early modern medicine. And the second edition in particular is fascinating because you've got all these, you know, you need to grind up skull of dog and bone of toad and proper good old medieval stuff. But alongside, you've got these recommendations that the best way to deal with this new disease, smallpox, is to go away and read Pitcairn. But this book's specific design for and is set up as a set of easy remedies for the poor. So I think what you've got is a really interesting period in medicine here, where you get this glimpse of of high Edinburgh medicine being practiced at the university and at the colleges, but then you've got little glimpses as well of what's actually happening out there when people have got toothache, or people have got a headache, or an upset stomach, and the various concoctions and the way in which the new opiate starts to work its way into these recipes and these remedies, but alongside an existing substance which is obviously being used in in herbal or folk or whatever you want to call it, remedies that people are using on a day-to-day basis. So again, it's not just local and global. It's what happens to the global when it hits a local, which is already itself disaggregated and fractured.
Yeah, I mean, this is something that I've been really trying to unpick recently. I've been thinking a lot about this idea of Edinburgh as the AIDS capital of Europe, and this idea of AIDS capitals in general, and what kind of that AIDS capital label does in the media. And like you see it trotted like you see it trotted out all over the place, especially in the 80s and 90s, but up until the late 90s, places get called AIDS capitals. And if they're not being called AIDS capitals, it's gay capital, and then there's loads of HIV, and they're kind of trying to connect those two ideas within the papers. So I've got a few quotes that I pulled the other day, and one of them is, in terms of the AIDS epidemic, Edinburgh is a microcosm of New York. And that's from a Daily Mail article. And I'm really interested in thinking about this because you see it all the time. Edinburgh is either San Francisco or Edinburgh is New York. So there's, in terms of the way that we tell stories about Edinburgh as this kind of little city, and this beautiful city with a dark, seedy underside, and it's all the drugs, and it's all the HIV, that is so much a part of this 1980s, 1990s moment. And it only works if you're not writing about Edinburgh from Edinburgh. So it's very much this kind of weird perception, this kind of double image of Edinburgh that relies on this kind of dichotomy between the beautiful and the dark, but also